Good day, and welcome to the Center for Oral Disease Prevention and Population Health Research inaugural Distinguished Interprofessional Education Lecture Series. I'm Dr. Bruce Dye, Chair of Community Dentistry and Population Health at the School of Dental Medicine on the Anschutz Medical Campus here at the University of Colorado. I'm also the Director for the Center for Oral Disease Prevention and Population Health Research. Our goal for this lecture series is to facilitate interprofessional education and collaboration by bringing together an oral health provider with another provider in healthcare to present 7 things that each want the other profession to know. In the spirit of interprofessional recognition, our 7 Things series was born out of a conversation with Dr. Dan Matlock, a geriatrician and professor in the School of Medicine, who mentioned how he would like to know the top 7 things that geriatric dentists believed was important for geriatricians to know. Hence, the 7 things is also an opportunity for us to chip away at those things we don't know. Our future plans for COPPR's 7 Things lecture series includes providing a distinguished IPE lecture every semester, about 3 times an academic year. We're currently working on developing our next 7 Things lecture for summer semester on the topic of pediatrics. Our distinguished lecturers will be Dr. Denise Ogden, Assistant Professor at the School of Medicine, and Dr. Catherine Chen, Interim Chair of Pediatric Dentistry. Today's inaugural lecture is a conversation between a geriatrician and a geriatric dentist, sharing 7 things they would like the other to know. It's also apropos that our first 7 Things lecture is on geriatrics, as it celebrates the strengthening of our patient care collaboration between the Division of Geriatrics and UC Health Seniors Clinic and the School of Dental Medicine's newly initiated Seniors and Special Care Clinic. I hope you enjoy today's lecture and you walk away with at least 3 things that may help you in considering care for an older adult, especially a senior who may have several comorbidities. Our guest lecturers today are Dr. Sophia Clark and Dr. Sarah Dirks. Dr. Clark received her medical degree from George Washington University in the District of Columbia, and then completed her internal medicine residency at the University of Colorado, and later moved to the University of Michigan to complete her geriatrics fellowship. She currently works mostly in outpatient setting at Seniors Clinic at Anschutz and Lone Tree, as well as inpatient and rehab settings. Dr. Dirks completed her dental degree at the University of Texas Health Science Center in San Antonio, the nation that we commonly refer to as Texas. In 1992, she joined the faculty at UTHFCA, I never get there, where she completed her HRSA-funded geriatric fellowship in 2006. Dr. Dirks opened a private practice specializing in older adults and returned to academia later last year as a faculty member at CU School of Dental Medicine's Department of Community Dentistry and Population Health. For awareness purposes, this lecture is being recorded and will be posted on COPPR's Learning Hub website. The School of Dental Medicine will be providing dental CE for synchronous attendance today only. Information on how to claim dental CE will be provided at the end of today's lecture. Following the conclusion of the presentations, I'll return to help moderate audience questions. Once again, thank you for joining, and Dr. Dirks will now get us started.
Well, thank you very much for this opportunity. I want to thank COPPR especially for hosting this series. And I also want to thank Dr. Sophie Clark. And we've enjoyed a lot of organic conversations as we put this course together, which is something that I found a little bit unexpected, but probably one of my favorite parts of actually putting this lecture together is to be able to speak candidly with a geriatric physician and to learn more about their world. We're going to start out with door number 1, which is the confluence of complicating factors when you look at geriatric dentistry. Most of us have been to the dentist, and you'll see in this radiograph a tooth where a filling fell out. Now, most of us have been to the dentist. We've had something that we've needed done, and the dentist will look at that tooth and they'll think, okay, what do we do? Do we do a composite, an amalgam? Does it need a root canal, crown? It's pretty much tooth-centered. And then they'll look at your insurance. Do you have Medicaid, private pay? Your tooth will get fixed and you're on your happy way. In geriatrics, we're really focusing more on person factors. Some of the main factors we look at are medication considerations, timing of the oral surgery with medications, medical concerns. But one of the things that I would, which I think my geriatric physicians, geriatricians realize, is the functional limitations sometimes take precedence over what I want to do with the tooth. For example, can my patient tolerate x-rays? In this particular patient who was bedridden and who was self-traumatizing their mouth, we could not safely take a radiograph. Now, it's not my favorite thing to extract a tooth without a radiograph, but in this case, there was an aspiration risk. The tooth had to be taken out, and I was very lucky that it was tooth number 8 and it was tooth in the front. So we were able to take that tooth out. This is a patient who probably cannot safely tolerate a high-speed drill. And this is the patient who probably a geriatrician would not want them to be sedated because they probably are too medically frail, definitely for the operating room. So we do have to look at person factors. A lot of times even are more take over what we do and how we proceed than even tooth factors. Number 2 is dentures are not teeth. I know that's a little bit tongue-in-cheek to say, but I took a photograph of what dentures look like from behind. And I want you to think about dentures as an intraoral prostheses that are made of hard plastic. And you can see from a backwards view looking out, there's a lot of plastic. The palate is covered with plastic on the upper denture, on the bottom denture. It competes with the tongue. And I think that one of the issues is that happens is marketing and commercials really for dentures and for denture adhesives try to portray the ideal situation, which I like to think of dentures more as in a artificial leg. We like to think of artificial legs as something that can help us win a marathon and we can run miles. But I think the reality is with older geriatric patients, an artificial leg may be something that that they may not even be able to utilize. They can utilize minimally. So I feel like it would behoove not only geriatricians, but general dentists to really think about these dentures as a prosthesis and to be able to let the patient understand the limits. One of the things I want geriatricians to also think about is even though a patient could function well with a prosthesis in their 70s, when they get to be in their 80s or 90s, then we might start to see some very much diminished neuromuscular control, and they cannot function any longer with a prosthesis. The other thing I want you to think about is that losing your teeth is like losing a body part. We see resultant depression, more social isolation, just like losing a limb. Losing teeth can be very depressing. When you lose your teeth, I don't know, if you look on the left slide, on the left of the slide, you'll see a retracted tongue. You can barely see the retracted tongue. When the tongue retracts, the floor of the mouth comes up. You can see that there's very little bone support. And right now on the left, this would probably be termed a dental cripple. Could they even wear a denture? The lady on the upper right, who had her dentures missing for years, what happened was her orbicularis oris mouth or muscles actually shrunk and atrophied. And then you couple that with angular cheilitis. And even though she had adequate neuromuscular control, and I would say adequate bone for me to make a denture, I could not even get a denture tray into her mouth to fabricate the dentures. And then one other example, what happens when we lose our teeth is, and the gentleman on the bottom part of this slide, he had advanced dementia and he lost the neuromuscular control and cognitive ability to adapt to dentures. And you can see even if a denture fits well, he didn't know how to actually manage the denture. So these are things that I think about when I start seeing my patients in their 70s starting to get their teeth pulled. I start to think, well, what's going to happen when they're in their 80s? So what we're setting up for is number 3, what I call a perfect storm. And I think that anyone who works in geriatrics is aware of a perfect storm. And the number one reason my patients tell me that they haven't been to the dentist for a while is because medical problems take a priority. And I think all of us understand that. Medical problems start to creep up, and then after the medical problems are stabilized, then hopefully they say, okay, now I'm going to see the dentist. But by that time, there's a lot of other things that are going on. And I'm not going to read the slide, but I did want to highlight the concept of extractions, because extractions, I would say, are one of the single most issues or treatments that start to put an older adult into extreme nutritional vulnerability. And one of the phrases I teach my students, they know this phrase well, is we want to attempt to keep salvageable teeth serviceable. And the reason for that, when I have a 70-year-old patient, I'm planning on them living to be 100. In private practice, my average patient was 86, and I planned on them living at least 10, 15 more years. And so we have to realize that once you extract teeth, that's when you have severe bone loss, and we could unintentionally make a dental cripple. This was a patient who was nonverbal with advanced dementia, and I had a very sharp geriatrician who requested a dental consultation. Why? Because the patient quit eating, and it was 2 weeks. And the geriatrician thought, well, maybe something dental's going on. And sure enough, the patient came to my office. Patient could not give me any history of the pain or why they quit eating. And a geriatrician may think, oh, well, it's geriatric wasting syndrome. This patient has advanced dementia. But I lifted up her upper lip, and what you can see there is something actually very simple happened. A filling fell out. And the filling, once it fell out, left what I would describe as a razor sharp, it was like a razor blade, point. So every time the patient bit down, she traumatized herself. Too painful to chew. And thankfully, after it took about 2 weeks and some unintentional weight loss that we finally got to the bottom of it. And I had that tooth smoothed out in like 5 seconds. And what an easy solution to what could have been a devastating decline for that patient. And one other thing I want to mention is food is calories, but especially for older adults, well, probably for everyone, we have to remember that food and meal times hold significant meaning other than calories. It gives us a sense of routine, a sense of pleasure. You look at food throughout history, and it provides spiritual meaning to many patients. This is a photo of my patients at the University of Texas Health Science Center after I had seen them in the geriatric clinic. And the most important thing for them was they needed to get back to their facility so they could get back for lunch, so they could eat with their friends. And I think we have to remember that food is much more than just calories. And sometimes it's one of the last forms of routine and pleasure as we age. The fourth thing is I want geriatricians to know is this is cool. It may not sound cool right up front, but I think after I go over it, you may see that it actually is a pretty cool development in dentistry. We have a product called silver diamine fluoride. Don't confuse it with regular fluoride. Regular fluoride is meant to prevent cavities. Silver diamine fluoride is actually a cost-effective, non-invasive alternative treatment for cavities, for caries. This is a very typical patient that I would see who's maybe in their 80s and 90s and who hasn't gotten regular dental care. We know that older adults have severe dry mouth from medications. And if you looked at this patient and knew the totality of circumstances, this patient cannot tolerate invasive dental care. This patient cannot safely tolerate me having a high-speed drill in their mouth. It's not safe for the patient. It's not safe for the providers. So what we have now is a material that we can, and I usually tell the patient, paint it on, and it will actually arrest or stop caries. And root caries, what you see here, is one of extremely common in older adults. And it's very cost effective. I mean, to put fillings on all those teeth or crowns, if that patient could tolerate it safely, would be thousands of dollars. And you can imagine the number of appointments it would take. So silver diamine fluoride is a new product, and what's well, it's not that new actually. It was approved, I think, in 2014 by the FDA. We're using it for an off-label use. But what's really exciting is the American Medical Association approved the application of silver diamine fluoride for the use by physicians or by the medical community, and the code goes in effect July 1, 2023. So I think one of the challenges will be, how do the physicians determine how to maybe delegate application of this product to their patients, maybe delegate it to nurses or appropriate staff. But in geriatrics, I like to look at it, it will keep salvageable teeth serviceable. If you look at the photo on the bottom, I could paint silver diamine on those teeth that really look less than ideal. And we really do not want to go about extracting teeth that aren't perfect. I tell patients, we don't need perfect teeth. We need teeth that are serviceable and that you can use to chew with. Geriatrics is those of us who work in geriatrics have been using silver diamine fluoride for a while, but I think the real momentum came from the pediatric medical community, and the promise for using it for nursing bottle caries is huge. So nobody wants to sedate a 2-year-old, and so it's really going to be interesting how we see more of that getting used. The next topic I want to mention is what I call the problem of pain. Pain is a subjective feeling that is really impossible to accurately and consistently quantify sometimes when you're talking about oral pain. But what I like to look at pain is, you know, we've all had something hurt on our tooth and we think, oh, my toothache went away. We want to believe that that means things are getting better. Well, and it can, and once again, but often it's not getting better. Let's look at, once again, the x-ray on the upper right. If you look at the x-ray on the upper right, we see the dark area within the tooth is I would call it a voluptuous, healthy nerve, pulp, arteries. That person is going to feel pain because that pulp is active and alive and healthy. If you look at the x-ray on the bottom, you can barely see the nerve. And just like other end organs that we know as physicians that can become damaged, and I put an illustration on the bottom of what happens in the glomerulus of kidney disease patients, you get the microvascular damage. And I like to call it tooth pulp neuropathy. It's probably not quite the accurate word, but I have found that with my patients who have dementia, who have teeth, if I look at their x-rays, very often the nerves are calcified, they're atrophied, you can't see the nerve. We see it in aging. If you look at the pulp of an aging person, that pulp shrinks, makes root canals sometimes impossible. But even in private practice, if I had an older adult with a calcified nerve, most of the time, I wouldn't even have to numb them up for a filling. So that's something to keep in mind. So if you have, as we know, with significant diseases like cancer, you may not have any pain. And for example, the patient on the left had significant tooth disease, but since her nerve was the nerve in her tooth was experiencing tooth neuropathy, she didn't express pain until the necrosis had actually spread to her tissues. You can already see pus is about to pop through that lesion. Very painful, but we don't want to wait till a patient experiences that kind of pain. The lady on the left was a patient I had with advanced dementia who had worn dentures forever. And I went into her room and I asked her, Mrs. Smith, is your denture causing you any pain? And she looked right at me and said, no. And it's tempting when a patient says they don't have pain just to move on to the next patient. But what I try to teach my students is, no, you've got to take the denture out. So we took the denture out, and what did we see? We see what I would like to call a decubitus ulcer in the mouth, but we sanitize the language in dentistry and we call it a denture sore. But I would argue that's a decubitus ulcer in the mouth, and they can be very severe, very painful. Why did that patient not tell me she had pain? She was on pain meds. She was an unreliable historian, but we always have to look. The sixth thing I want to mention is aspiration pneumonia. This is an issue I know that geriatricians deal with a lot, and it's one of those issues where I think we can potentially see a lot of synergy as providers to the geriatric community. Prior to this presentation, I went through some I looked at the published scholarly work to see what's out there. And there is a lot of work in the medical literature, dental literature, infection journals, talking about the role of aspiration pneumonia and poor oral health. Just looking at this picture, you can see that it would not be that unusual to think that this bacteria, this food debris could easily end up into the lungs and cause aspiration pneumonia. Aspiration pneumonia is one of the main causes of death in institutionalized nursing home residents. I listed 4 of the key points from this article, and the reason I listed this article is that it's a summary of what we know now regarding, in general terms, what we know about the link between the mouth and aspiration pneumonia. It's a really good summary, and it came out in 2021. One of the things I would like my physicians to know is that a lot of our older adults wear prostheses. On the upper left is a partial denture, and I apologize, that looks really nasty, but that is not uncommon. The reason is it's twofold. One, our patients get limited dexterity, but the other is, unless you're a dentist, you probably don't realize that dentists make these partials with clasps that are actually intended to be a little tricky to put in and out. The way I want you to think about it is if we didn't make it a little tricky to take it in and out, that partial would literally move up and down every time they eat. So as a patient ages, and they may not have that dexterity to be able to manipulate what we call the path of insertion, they may not be able to get it in, or they get it in with a lot of difficulty, so they never want to take it out. In the patient on the right, on the patient on the right, let's see, we have someone who's had a stroke and someone who now has swallowing difficulties. And even though their front teeth looked relatively clean, if you lift up their cheek, it's not uncommon to see food pocketing. And once again, looking at these 2 photos, you can see it's not that unlikely that the mouth can be a reservoir for bacteria. The last thing I want to talk about does not sound very exciting, I know. It's a bacteria, and we call it P. gingivallis. And P. gingivallis is one of over 700 bacteria in the mouth. And the reason I want to talk about P. gingivallis is because I had a dentist, periodontist, once told me it was the devil of oral bacteria. And I think that's an okay way to look at it. This is the main bacteria that causes gum disease, severe periodontal disease. And P. gingivallis produces gingipans, which are basically enzymes, which will disrupt the host inflammatory responses, and it will degrade host proteins and tissues. And I'm about to show you a slide that shows you how badly it can degrade tissues in the mouth. But what's really fascinating, and I think I want to have all of us keep our ear to the ground, is to look at the research that's showing how the systemic dissemination of P. gingivallis from the mouth, from the gingiva, actually is being found in other sites of the body. So there's different diseases that the researchers are looking at. I listed the ones that I think as geriatricians that might be of most interest to us: Alzheimer's disease, rheumatoid arthritis, heart attacks, and so on. Interestingly, when I was getting ready for this presentation, the CU Anschutz News published an article in just a couple weeks ago on can flossing help prevent Alzheimer's and strokes. Alzheimer's disease has a lot more research behind it, I think, than some of the others. But that's a really good article to look at to see who's working on some of this research here on campus. There's a lot out there, and I listed some of the main systemic review articles that are pretty recent. But another quick YouTube that I find very interesting is they interviewed at the Alzheimer's Association International Conference a Dr. Michael Detke, who talked about his idea and his plan and his medication on targeting P. gingivallis infection to treat Alzheimer's disease. So my last slide kind of pulls this concept all together in that we know that the oral cavity is an important interaction window between the human body and the environment. We know that. And looking at these pictures, and I have photos that are very extreme, but they're made there to make a point. We don't need that extreme of a disruption of the gingival architecture to think that bacteria can enter the body systemically. But the big question that the researchers are trying to answer is P. gingivallis merely a bystander? I mean, it's being located in the brains of Alzheimer's patients and other parts of the body, or actually more importantly, does P. gingivallis induce pathogenic changes in other parts of the body, as we know it does in the mouth? And so with that, I want to introduce and turn this over to Dr. Sophie Clark, MD Geriatrician.
Thank you so much, Sarah. And I really also value our collaboration, and I've learned a ton from you. And I think even in my own practice, I've referred many patients that I would not have realized I needed to refer otherwise. And it's really an exciting avenue. And I hope that you all in my presentation also see the significant overlap between Sarah and I's approach to patients, because there's a lot of overlap there. Yeah. So the first thing is geriatrics is not cut and dry. So this is a patient came into my office who had been lost to follow-up, hadn't seen a doctor in a few years. And then it had come into the office 2 or 3 times with constipation. And so constipation, as you can imagine, especially in an 80-year-old, is a really common complaint. But there was just something about this patient and the fact that this was new constipation and she kept on coming into the office that sort of got my spidey sense up. And so I ended up getting a CT scan, which is not something that you would routinely get in the workup of, and at the initial step, at least for constipation. But this patient ended up here. This is the scan, and a CT scan basically it takes horizontal snapshots of the body, going from the head down to the feet. And so right here, this is your bones. These are your pelvic bone. This is your spine. This is another one of your pelvic spine. And then you can sort of see in the middle that there's this large tumor that's 7 centimeters by 3 centimeters. So a pretty large tumor. And her only symptom was constipation. She didn't have any pain, didn't have anything. And so when we think about geriatric patients, just like how pain is not a reliable indicator in dentistry that a problem is going on, you have to pay more attention to the subtle signs of disease. So a patient who has a raging infection is actually sick enough to be in the ICU might never mount a fever, for example, just because the immune system doesn't have quite the same response. So in geriatrics, things that sort of perk our spidey senses up are unexplained weight loss. Change in function is a huge one. So if a patient all of a sudden can't go to the grocery store by themselves, or can't play bridge, or is not able to shower independently, that can be an indicator that something's going up. Changes in behavior, changes in mental status, especially among patients with dementia, can be an indicator that something is going on. And then really any new symptom should at least raise your awareness that something might be going on. Obviously, you can't, fully do an invasive workup for everything, but just it should sort of be an indicator of something that you should think more about. So second is frailty matters more than age. So what is meant by frailty is basically over the lifespan from aging, your body's change, and then also you accumulate all of these different medical conditions, you accumulate medications. There's just a lot of factors that are coming together that affect older adults' ability to bounce back from an illness or any kind of insult. And so I kind of think about it as like a ball without air, depending on your frailty status, you aren't able to have any reserve, aren't able to bounce back in the same way. And so age and frailty don't go together. You could have a 90-year-old who lives in a nursing home and is bedbound, and you can also have a 90-year-old who is still living in the community, drives around, has extremely, extremely active person. And so you can't just look at someone's age and determine their functional status or how much reserve they have. And so frailty in a lot of ways is hard to define. It's a gestalt, but there are certain things that you can ask or pay attention to that can kind of indicate if someone's frail or not. So things like fatigue, like are you feeling so tired all of the time that you can't really do your normal activities? Are you sleeping a lot of the day? Can you walk up a flight of stairs? Can you walk a block? Do you have a lot of medications? Are there a lot of illnesses going on? Are you thin? Have you been losing weight? And so I think this is something, if a dentist is approaching a patient, you don't have to ask all of these questions, but really pay attention. When you see your patient walking into the office, if they're walking really, really slow, or they're looking thin, or, you ask them, how are you doing? And they say, oh, I haven't really been up to much anything. I've just been staying at home, and you previously known them to be really active. This can be sort of an indicator of frailty. And so where this matters is when you approach that same patient that I showed you earlier, who's an 82-year-old with a pelvic mass. If you told me this person was 72 or 82, that wouldn't really affect how you would approach the patient and think about different treatments for the cancer. What would change it is if you told me that this is an 82-year-old who lives alone and is managing everything, including her finances, completely fine, or this is an 82-year-old who has been in and out of the hospital because they have really bad heart failure. That would change my mind much more. Their frailty status would change their mind much more than their age. And kind of like Sarah talked about in terms of disease-centered factors and person-centered factors, in geriatrics, we really try to be person-centered and think about all of the different things that go into getting care, especially as you get older. And then you just want to make sure that the things that you're doing, if you're putting an older adult through radiation or chemo, they're more likely to experience negative side effects. And so keeping that in mind and making sure that you're really choosing treatments that make sense and are also really focused on a person's goals of care or what it means to have a really high quality life. So the next is weight loss, the downward cascade. And so when the patient that Sarah was talking about was in the nursing home and had a ton of weight loss, I guarantee that geriatrician was like, oh my God, this is terrible. This is awful. We need to do something about this, because it can lead to something called sarcopenia. So these are two different, these are MRIs of thighs. This one on the left is a healthy 20, 30-year-old. The one on the right is an 80-year-old. And so you can just see the difference in the muscle mass between a 20-year-old and then an 80-year-old over here. And so loss of muscle mass is called sarcopenia. And why we really care about this is because how much muscle you have is really linked to your function. And so you can imagine this person might not be able to walk upstairs or might not have the same aerobic fitness as they had before because of their sarcopenia. And so what you really want to avoid is you want to avoid weight loss that's leading to sarcopenia, which leads to reduction in function, because the worse your function is, the worse you're going to be able to tolerate any kind of illness you have. And then, you know, poor function also portends for like even more weight loss. So if you're not able to get food for yourself, if you're not able to cook for yourself, which is a function, that leads to weight loss, which then impairs your muscle mass even more. And so this is really a downward cascade that you want to do everything that you can. And I think that that's where dentistry is also helpful, because it's one way that you can address malnutrition. And then next, hip fractures are dangerous. So hip fractures, especially in 80 and 90-year-olds who are independent, really are one of the biggest things that can threaten someone's independence. And so this is a study that looked at like 700 older adults who had sustained a hip fracture. And in the year following hip fracture, the outcomes are pretty bleak. And so this study didn't look at this, but some studies have found that the 1-year mortality rate after a hip fracture is up to 30%. So that's a mortality rate that's on par with an aggressive cancer, a heart attack, heart failure, like other conditions that we consider really medically scary. But hip fractures to geriatricians are really scary. And so in this study, they found that only a third of patients return to their pre-fracture ability of activities of daily living. So that's their ability to bathe, get out of bed by themselves, just basic things that you have to be able to function. 34% return to their pre-fracture mobility function, and 41% return to their pre-fracture climbing function. So most people aren't returning back to their prior functional level. And this is the main reason why people have to move into nursing homes, and it can really have a dramatic effect on their life. And so one of the things tools in our toolbox that we can do to prevent a hip fracture is to treat osteoporosis. So bisphosphonates are used to treat osteoporosis, and they're effective. So when used appropriately, they can prevent vertebral fractures by 44%, and vertebral fractures, back fractures, are a huge reason people get chronic pain, and there can be really debilitating. Hip fractures, they can reduce that by up to 40%, and then they can also reduce other osteoporotic fractures. So when there's really not much that we can do, otherwise, there's not a lot, you can reduce someone's fall risk, but at the end of the day, there's not that much you can do to target and prevent hip fractures. We really do use bisphosphonates for that reason. And that's not to say that we don't understand that there's side effects of these medications, and especially we're aware and we screen for risk factors for osteonecrosis. And I think that that's also an area where geriatric dentistries and geriatricians can work really closely together. But this is why we care so much, is because we really worry about one of our patients who is otherwise thriving, getting a hip fracture, and then just going on a downward spiral. So pocket talkers. So these are really neat devices for when you're trying to talk to a patient and their hearing is so bad you completely can't hear them. We have them in the geriatrics clinic. What a pocket talker is basically, these are headphones, this is a microphone, and you speak into the microphone and it magnifies whatever you're saying. And it can basically make it so you go from having no conversation with someone with really bad hearing to just having a normal conversation. So something to consider, you can get them for $27. I don't know the quality of this one, but really something that you could consider getting for your dental practice and just keeping it on hand. Don't assume cognition. And so what I mean by this is just because an older adult doesn't understand you, don't assume it's because they have dementia or there's a problem with their cognition. Hearing loss is certainly something that can mask itself as a dementia or a problem with cognition. Other things, that dentistry is complicated. When Sarah talks about all of her dentistry terms, I don't understand it, and it's not, and it's just, so make sure you're talking to someone in patient-friendly language. And so the reason for this is even your risk for dementia increases with age, and even among the most at-risk people, a third of patients age 90 or older have dementia. So the vast majority of people that you're encountering do not actually have any kind of cognitive impairment. And then this is just sort of a clarification, because I think it can be very confusing when people say dementia and Alzheimer's disease. What do they mean? Dementia just refers to any kind of progressive neurodegenerative process. So anything that is going to get worse over time and eventually will lead to someone's death if they live long enough. So Alzheimer's disease is an example of dementia, vascular dementia from strokes, Lewy body dementia related to Parkinson's disease. All of these things are types of dementias. And then I just wanted to talk briefly about how dementia is diagnosed, because I think it can also help you understand how to approach patients with dementia. So typically what happens is an older adult or a family member comes in and says, my short-term memory isn't as good as before. And so that leads you to do a cognitive test. And so this is a MOCA. This is a common screening test for dementia that's done in the office. It takes 20 minutes. There are more elaborate tests that you can do. A neuropsychiatrist can do a test for 2 or 3 hours. But basically, if you score below the normal range on this test, you're considered to have a cognitive deficit. And so this is enough to qualify you as having mild cognitive impairment, but it's not enough to qualify you to have dementia. In order to have dementia, your memory problems or your thinking problems have to be significant enough where you can no longer carry out your everyday function. So that might mean that you aren't able to manage your investments anymore. You're not able to manage your finances. You might not be able to work anymore at the job that you were able to do. But you can have dementia and still be pretty high functioning. So I have patients, especially in the early stages of dementia, that are still managing their own medications. They're still driving. And so those patients, just because those patients are able to provide a good history. And when you're talking to them, they might be able to understand and consent to dental procedures. So just because someone has dementia, it doesn't mean that you just completely can't trust what they're saying. Certainly you want to be careful and be slower and make sure that they're understanding what you're saying. But I think that's just to provide a little insight there. And finally, the 4 Ms of geriatrics. So the 4 Ms of geriatrics is, I always address all of these things whenever I'm meeting a new patient, and it's really what we aim to embody in geriatrics. So at the top, and most importantly, it's what matters most to patients. And so both with dentistry, we're fixing our teeth so people can enjoy meals together and have a good quality of life that way. In geriatrics, we're managing their medical conditions really so that they can go about their everyday life and enjoy life and have a good quality of life. So understanding what's important to a patient guides how you address all different medical complaints. Someone's mobility, so looking at how well someone can get around, addressing sarcopenia, like I mentioned. This really affects whether or not someone can live independently or not, and is a really important cornerstone. Mentation, screening patients for mental illness like depression, anxiety, screening them for delirium, for dementia, paying attention to older adults' ability to think and mentate, because we do know that they're at risk for things like dementia. And then also always thinking about medications, being aware that patients, especially frail older adults, are more at risk of side effects from medications. A lot of medications can cause problems and cause people to come into the medical office with a new complaint. And so really just making sure that we're using medications judiciously. And so really, this is what any age-friendly health system really aims to address. They aim to follow evidence-based guidelines on how to address problems in older adults. So that really means looking at the guidelines and making sure that they make sense in the context of someone's frailty and overall health status, because that also goes along with do no harm. So just recognizing that older adults, especially frail ones, are more at risk for having bad outcomes from medical interventions or medicines, and then really just making sure that we align with what matters to older adults. So I've heard a lot of this and what Sarah talked about, and I think that this is really a shared mission that geriatric dentistry and geriatric has.